Today, thousands of young people in the summer of their lives are stuck in nursing homes with people in the winter of theirs. It is the wrong place. We work to get them out of nursing homes and into their own homes. We are the Summer Foundation, giving these young people their lives back. Please help us by donating to summerfoundation.org.au.
I have the pleasure of welcoming you today to our annual public forum. I'm Di Winkler, I'm the CEO of the Summer Foundation. I'd like to start by acknowledging the traditional owners of this land and pay my respects to their elders, past and present. It's terrific to see so many of you here today, and the main thing we're going to talk about today is the interface between health and disability. A special welcome to our audience in Newcastle and Geelong and people who are watching from home or at work. I'd especially like to acknowledge our ambassadors and other people with disabilities and their families, some of whom have travelled a long way to be with us here today. I'd also like to really thank our supporters, our volunteers, our ambassadors, our board members, and the terrific staff at the Summer Foundation who've helped us get us where we are today. So my background is I'm an occupational therapist. I've been working with people with severe brain injuries for over 20 years. And as an occupational therapist, I was often really frustrated by the lack of appropriate housing and support options. So in 2005, I started my PhD to provide an evidence base to change policy and practice. And then during my PhD, I interviewed people and I met a lot of young people in nursing homes and their families. And they described the long and difficult journey that they went on to get the information they needed to make an informed choice about housing and support. And they also talked about feeling like they were the only people in that situation. So the pragmatic side of me kicked in. I could see some things that I could do that would make a difference or outside my thesis. And I realised that research by itself wasn't going to resolve the issue of young people in nursing homes. So in 2006, I founded the Summer Foundation. So today we focus on the issue of young people in nursing homes, and we do three things: research, creating a movement, and housing. Our research provides an evidence base for change. We're creating a movement by supporting people to tell their stories, to raise awareness and to keep the issue on the public and political agenda. And we're building housing demonstration projects. So 2015 has been a great year with many significant achievements, and I'm just going to highlight a few of them for you today. There are many more, and you can read about those in our annual report. What was meant to be a quiet summer actually started off with a fantastic opportunity with the Senate inquiry into the adequacy of existing residential care arrangements for young people with disability. So our January was spent writing our own 100-page submission, but what was really exciting was the opportunity to hold some workshops and support 32 people with disability and families to write their own submissions. And then we supported 10 people to tell their personal stories at the Senate inquiry hearing. You could tell by being at the hearings that the stories made a huge impact on the senators. And then the Senate inquiry report that came out had 12 practical recommendations. So we're really looking forward to working with the governments, the NDIS and other agencies to see these recommendations implemented. We're also we're working to keep up the momentum that was created around the Senate inquiry with the media and the stories. While we wait for the federal government to respond to the Senate inquiry report. I'd like to thank the people with disability and families who are working with us, and some of them were working this morning, to produce 45-second clips where people tell us about their key messages. So these 40 clips will feature in a social media campaign called My Home Matters, which will commence within the next 2 weeks, just to keep the momentum up around the issue of young people in nursing homes. With our research, I'd really like to thank our partners at La Trobe University and Monash University. This year has continued to produce valuable research that provides a strong evidence base for change. The National Disability Insurance Scheme is an exciting and significant reform, and it's a part of the solution to the issue of young people in nursing homes. It's going to provide the critical funding that our group need to live in the community, but it's not a silver bullet. There are three key things we need to work with government on. We need to make sure that young people in nursing homes are included in the National Disability Insurance Scheme, that they know about it and are supported to register. We need to stop new admissions of young people to nursing homes, and we need to build more suitable housing. We know from our previous research and programs that young people in nursing homes, many of them will miss out on the NDIS unless we're proactive in finding them. So we have project workers in the Hunter trial site and in the Barwon trial site going from nursing home to find younger people and then supporting them to register, plan and get the services that they desperately need. This is also action research, so we're documenting what the issues and barriers are and then working with the NDIA and other agencies to improve the processes, develop solutions and make a difference. And this work is really critical. We need to get this right in the trial sites so that when the NDIS rolls out nationally, that will have an impact on the lives of young people in nursing homes nationally. This year's been the final year of our Tell Your Story program with digital story exhibitions. We'd like to really thank the Sydney Myer Fund. This year we exhibited 22 digital stories of young people in nursing homes in exhibitions in Newcastle, Cairns and Geelong. And it's been really wonderful to see the impact that these stories have had on people from all around Australia. The Ambassador Program, we welcomed 2 new ambassadors to the program, and we now have 17 strong voices and enthusiastic people who have personal stories of their lived experience and are just, I guess, ready to provide their perspective and tell their story to advocate for change. On behalf of the Summer Foundation, I'd like to thank our ambassadors and your families for your passion, your courage and your commitment as you continue to keep the issue of young people in nursing homes on the public and political agenda through your media opportunities and speaking engagements. Our mission is to see young people with disability have a choice of appropriate and affordable housing that's accessible. Our 2 housing demonstration projects show how well-designed and well-located housing that's affordable and adaptable and incorporates smart home technology with a really proactive model of support can actually increase people's independence and reduce lifetime care costs. We're really excited and pleased with the level of interest that our housing demonstration projects have generated from disability services, housing providers and government. So what we're doing is documenting our key learnings and the outcomes for residents, and we're actively encouraging other people to learn from what we're doing and replicate what we're doing. So we just recently launched a publication about the design features in our Hunter housing demonstration project. And if you'd like a copy of that report, you can download it for free from the Summer Foundation website. So today we're here to talk about the health and disability interface. As many of you know, that young people with complex disabilities and high support needs, they often move directly from aged care to directly to aged care from the hospital or rehabilitation. And young people, partly why they're in aged care is they fall through the gap between the health system and the disability service system. And then when people with disability are living in the community, their health is often not proactively managed, which often results in preventable health issues and hospital admissions. So today's panel will show why the collaboration between health and disability sectors is crucial for people with disability. The panel will explore how the health and disability systems can work together to more effectively in the future. And this is particularly critical with the national rollout of the National Disability Insurance Scheme. Before I start our discussion today, I'd like to just take a moment to acknowledge the life of Stella Young. Stella was a writer, a comedian, and a strong disability advocate. Stella passed away last year, and it was not long after she facilitated our annual public forum right here. And we'll always remember Stella for her spunk and her passionate advocacy for people with disability. I'd like to now introduce our panel facilitator, Dr. Mukesh Hakawal. Mukesh is a GP in Melbourne's West, the chair of the Australian Institute of Health and Welfare, and the past chair of the World Medical Association. In 2011, Mukesh was appointed as an officer of the Order of Australia. And Mukesh, thank you for being with us here today and facilitating for us. Thank you.
Good afternoon, and thank you very much for your invitation to come and speak, and for the magnificent work of the foundation, and the work that you do in advocacy and the way in which you do it, which is actually very savvy, very nuanced, and has, as you said, had some really great results. I was going to walk around a bit, but I think I'm going to sit down because there's probably too many people I'm going to block if I do sit down, so stand up. But I like to get out, but I won't today, okay? So I'm just going to make a few comments about this topic, which I think is very, very timely, because the way we stand today in Australia with our changes in government. And I suppose I probably see that with my current hat as the chair of the Australian Institute of Health and Welfare. When I took on this role just over a year ago, health was actually looked after by Minister Lee and the Health Department, and everything else was looked after by Minister Morrison in Social Security, Department of Social Services, and obviously those other ministers that were there. And we've had a reshuffle, and in that time things have changed with Minister Morrison, who's now taken on the role of Treasurer, and a new minister is in place in Canberra. So things are changing, and it's a good time to get our messages as a sector across to these various places. But where I sit across health and welfare, one of the things that we are very much moving towards with the Institute is working with the sectors in health and welfare and make sure that they have the right sorts of information, knowledge, and tools to make good decisions and lobby more effectively with the right facts and figures that we need to get the right outcomes for all of us. So as we launched this year Australia's Welfare 2015, which is a compendium really of a lot of facts and figures around the welfare sector, we did that with Minister Morrison in a housing project in Canberra. And that was very important to emphasise very clearly the benefits that housing and good housing does as a foundation part for all people, and to give people the opportunity to lead flourishing lives. That goal we all seek for everyone, to seek flourishing lives from the Social Determinants Commission of the United Nations. So I'm very grateful for the opportunity to speak here and to work with the panel who I'll introduce you to in a moment. But before I go into that, I just want to give you, and forgive me if you've heard it before, a little potted history about where I sit in this particular agenda, in particular the agenda around disability, but more specifically around acquired brain injury. In 2008, just the night of the grand final, I was a victim of an assault, and I was hospitalised and had 2 brain clots drained from my head. And if it wasn't for the people around me at the time, magnificent teams both in my immediate hospital and the rehabilitation hospital I was treated at, I wouldn't be able to sit here before you. So in many ways, the things that I knew, that you need good medical care, you need good ambulance care, you need excellent rehabilitation, I knew that already. But you know what? I suddenly felt it too. And that is something that's made me very much more an advocate and passionate in making sure that other people receive the same benefits that I received at that time, because it is life-changing, it is life-enhancing, and gives people that ability to actually go down that road of leading more flourishing lives. So in many ways, I'm extraordinarily lucky to be able to sit here and do the things I've managed to do, and Di very kindly introduced some of the things I've done in recent times, since that time actually. But that is no small part due to a remarkable group of people around me and the greater community, because the community support and community participation and community advocacy is what keeps those services in the public eye and be able to run them. So those parts of what we all do in our daily lives is an important part of all of this. So I'm going to turn to the agenda now, if that's all right. And you'll have before you some of the background information of our speakers. But I'm going to turn first of all to Jacinta, who is going to speak to us from the point of view of her work and research. And I'll ask you to introduce yourself briefly at the same time. Thank you very much. Can you please welcome Jacinta?
Thank you, Mukesh, and it's lovely to see you all sitting out there with such welcoming faces, and to know that there are other welcoming faces online and also at the sites both in Geelong and Newcastle. You know, when I got the topic for today's forum, I actually pondered on, believe it or not, over 35 years of working with people with acquired brain injuries. I've been in this field for a long time, and I've been really fortunate, I think, to have had the opportunity to learn from every one of those people and their families that I've worked with. So I pondered about that in order to sort of inform what I think is important about this healthy agenda, this interface between health and disability. And I thought I'd like to actually have a go at two questions. The first question was really straightforward. It was, what do I think, based on those learnings I have from the people I've worked with, would represent a healthy agenda across health and disability? And it didn't take very long to think about it, and it's beautiful because Mukesh has already made reference to this really. A healthy agenda in this context would enable people with chronic neurological conditions who also have complex needs with respect to care and support to get the best, the very best out of their lives, to get on with living well, to actually have a flourishing life in our society. That, I think, has to be the measure of whether the interface between health and disability is working. And I was comfy with that because I thought everybody I had actually worked with would say, yeah, I think, Jacinta, you've got something there. I wouldn't mind to get the best out of my life. The same as all of us would. And then I thought, well, okay, what do we need to ensure or to maybe make that happen or to help that happen? And I thought about maybe 5 essential ingredients. Now, I know everybody here is probably going to be able to add another essential ingredient. But I thought if we started with 5, you could think about the 5 that, again, from my learnings from the people I've worked with, I think are important in this interface, in this context. And the first one is, I think it's really important to make sure that who we consider our unit of care, who is the unit of care in this interface, and that is the person themselves and their family, the people around them who love them, who value them. That in fact, we don't get drawn into only always thinking about the individual in isolation, because we don't live in isolation. So firstly, all the way through the system, whether it be from admission to an acute hospital, whether it be living in a shared supported accommodation environment, that we think about the person as that person, that really special person in that really special family, or with those really special people who love and value them around them. So So that's the first essential ingredient, I think, that we maintain this concept of a social unit around the person. Then I thought, okay, what else would I really like? What else would people have said to me? And one of the things that I've learnt along the years is probably the most vulnerable times for people who have a severe acquired brain injury are times of transition. So my next wish, if you like, or my next goal for this interface is that we have a seamless continuum of care. Because a lot of people get lost at those transition points. And I worked with a lot of those people, and it's such a waste, such a really important waste from the point of view of emotional input, from resources, etc. And there are so many different levels of transition that we negotiate or navigate. There's the system transitions, the transition from health and mental health to aged care, the transition to disability support services to community care. There's transitions across our systems, and our systems are basically not very good. I wasn't going to say bloody awful, but they're not very good at actually working together. That seamless continuum of care is probably the most vulnerable part of our systems. But that's not the only transition you go through. There are setting transitions. You go from an acute setting to a rehabilitation setting, to a community setting. You actually move to your own home, go home, perhaps transition back to a supported accommodation setting. And again, people get lost along the way. Any services they had at home disappear when they go into an aged care setting. Services that they may have had in the aged care setting disappear if they move out. So our seamless continuum of care gets lots of rips in it. And also the other thing I think we have to hold on to when we think about transitions is that life is a series of transitions. So our continuum of care needs to be a lifespan, life stages continuum of care. Because clearly I actually have very different needs. We all have different needs today than we did at another point in our lives. Life has many life stages. And we need a continuum of care that recognises that what I want today may not be what I want in 2 years, 5 years, 20 or 30 years' time. My life will change. So that seamless continuum of care is such a big challenge. We now have an opportunity with the National Disability Insurance System, I think, to actually start out with making sure we set up systems that maintain that continuum of care. Next essential ingredient, and I'll be quick, is I think we need to provide opportunities to people to express their needs and to have their needs heard. The whole time I've actually worked in the healthcare system and in community and disability services, we have actually often given people the opportunity to express their needs. But often we don't hear that. So we need both. We need a collaborative system. We need a system that collaborates between the person, their family, healthcare workers, disability support workers, all of the people who actually go into helping that person get the best out of their life. So we need a collaborative system that listens. We also then, if we're going to listen, we need a system that actually is able to provide ongoing, not once off, but ongoing and timely services and resources. I think the NDIS is potentially going to give us a really good opportunity for actually doing that, particularly for this group of people. But we have to be so alert, because what we have to have, we will never get the outcomes we want to get unless we actually have a flexible and responsive system. And the final essential ingredient is I think we need a system that has support built into it. Now by that I mean, one of the things that I've noticed is that as you go through the health disability system is you actually all of a sudden realise I have no idea what's going on here. I don't know who to turn to. We need a system that has that support built in, that you either have a mechanism or a person that travels with you, that you can turn to when you get completely confused by what is going on around you. That in fact there is a place to go, a person to go to help you get the best out of your life through those systems as you transition through your life and transition through the sectors that we have. So that's a starting point. Thank you.
Thank you very much. I'm going to go slightly out of order, and I've asked Jackie to take the next pew, and then we'll come to Frank. And if you're comfortable too, Vicky, if we could ask you to speak as well after. Thank you. Please.
Thank you. Like Di, I'm an occupational therapist by background, and I'm currently working at the Alfred Health ABI service. There's a number of things I have to say on this topic, and I'd like to sort of start by acknowledging where we've come to in the last couple of years. With the support of the Summer Foundation and many others, we've been advocating for a long time that there's a desperate need for increased beds for rehabilitation for people who have acquired brain injury. We're really fortunate that last year we did open a new statewide service on the Caulfield side of Alfred Health, which has opened up 42 new beds. And along with that, we have a community team and a transitional living service. As a result of that, we've moved some of the blockage in our health system, where for a long time a lot of our patients that we know were stuck, if you like, in the acute services, where they weren't getting the care and the rehabilitation that they required. And now we've moved into this great new service, we're still having a blockage. The blockage has just moved now to rehabilitation and getting the patients out into what Di's described as affordable and suitable accommodation. Our social workers work in many, many hours, and a number of them here today, and they can attest to this, that they spend a lot of time trying to find affordable housing that's appropriate to the needs of the clients that we're working with, are in close proximity, if you like, to their family, but sometimes this just isn't possible because they often have such a scramble to try and acquire something. They then work with trying to get the ISPs for the patients, to get them some funding to be able to live in these and get the support they need in this accommodation. So I think we've addressed one need, although there can always be more rehabilitation beds, but I think we really need to then say, what do we do now? There's still a desperate need for affordable and suitable accommodation for this client group. We're very fortunate in the ABI unit that we have a community team attached to the service. And Jacinta beautifully described the transition often from acute to subacute to community. And we're now in a position where we actually do transition our clients from the inpatient unit to the community. And we have the ability to follow our patients into the residential care if that's where they're going. And we can provide that support, we can provide the education in helping both the patient, the family, but also the facility assist in understanding what the needs are. So often we've seen people just transition from the acute or rehabilitation setting straight into a nursing home in isolation, and the facility is left trying to understand what the person's needs are that are often very, very different to the aged care population that they'd often see in that setting. So we've had some beautiful examples this year where we've been able to support some clients being transitioned, and as a result, it's been a much smoother transition. The other fortunate thing that we've been able to do is we're able to follow our patients. So we might not see them every week, but we will monitor this patient group for their lifetime if that's what's required. So this, Di mentioned that a lot of young people in nursing homes are lost. We don't know who's where, and getting them perhaps into the NDIS, we just don't know where they are. So unless they have a fantastic advocate that's able to do that for them, they can get lost to what supports are available to them. With this new service, we're hoping to reduce that if a patient is finding that they need some support, it might be that they improve, which we've had a number of cases this year where we've actually moved patients from a residential facility back into their own environment because they had access to rehabilitation, which hasn't been previously available to this client group. So we're hoping that through our service, a small amount of people will be able to not be lost to the system. Unfortunately, this isn't available to all patients who transition from rehabilitation, and I think that's one of the things we need to continue to advocate for, that this transition is very often confusing, it's also very stressful, and a number of issues do come up during that transition period that families are left to deal with, and it's a very complex situation for many people. We also find that with our discharge planning is that it's really delayed. It's really delayed based on funding availability. So again, our social workers do advocate to try and get packages, but sometimes it's luck of the draw. If new funding has been made available, then you might get somebody on a package. Other times they can wait. And whilst this person is waiting, the bed that they may have been secured, this precious accommodation that is very far and few between, is left waiting for them to get the appropriate funding to be able to transition to that accommodation. And then the next challenge that we have is the appropriate equipment. Again, the funding for appropriate equipment for people is still very limited. It's limited in often it's capped to a certain amount, and so then there's a gap funding, which at times people can get through disability support, but often it's left to the families. The waiting list to get this appropriate equipment so that people can live a life in the facilities that they're being transitioned to is crucial. If you don't have the appropriate wheelchair, if you don't have the appropriate car modifications, you are then a loss to being able to access the community very easily. So we can look, accommodation is a delay, getting a package is a delay, getting equipment is a delay, and all of this time the patients are not being able to get on with their living. So I think whilst we've addressed some issues in the health sector by opening up more rehabilitation, I feel there's a lot more that we need to do in order to support people to get back into the community and live a life that they're intended to do. Just going to refer to my notes quickly here. One of the other big gaps that we also have noticed is the challenge with the waiting time is it means that patients who are waiting for that rehabilitation bed are actually stuck in an acute hospital many times and their rehabilitation hasn't commenced. So one of the challenges I think we have going forward, it will be very interesting, and we're very hopeful that the NDIS will, I know it's the magic bullet we refer to it as, we're hoping that by having the NDIS come in, that in particular the equipment needs of people transitioning from rehabilitation to home or other facilities is supported by NDIS. That the gaps in funding, that the period of time that they have to wait to get this appropriate equipment is reduced, and that the families aren't having to pay a significant amount of money whilst the equipment comes in. So we're hoping that the NDIS will be able to bridge this gap in funding and the wait that's currently required with funding. One of the other things that we're also hoping to do is see more vocational rehabilitation. Vocational rehabilitation is a very specialist area, and a number of the previous specialists in this area are no longer in existence. So in February this year, the CRS no longer were taking referrals, they were no longer a service available. So again, there's another gap. So it's a big gap for patients who are transitioning, recovering from their acquired brain injury and getting back into some sort of vocation. So again, this magic bullet we're hoping will increase some vocational supports available to people as well. The last thing that we want to touch on is in the access to community rehabilitation. As Di mentioned, there's a number of people living in residential facilities who we don't know about. So again, I think it's really crucial that we find out who is where and ensure that everyone does have that great understanding of what supports will be available, what therapy supports will be available with the NDIS. It's going to be challenging with the rollout being so staggered. We're a statewide service in our brain injury service, so when we're discharge planning, it will be, some regions will be on the NDIS and others won't go on until 2018. So that will be an interesting transition for everybody involved. And again, it will be a bit of a monopoly on where you're living as to when you do go on the NDIS. And that's going to be unfortunate, but that's the system that we're going to be working in. So we're hoping with the NDIS that a lot of the challenges we see now with the transition from rehabilitation back into the community will be met by the funding available through NDIS.
Okay, thank you very much. I'm very pleased to let people know that we do have someone from the NDIS listening in from Geelong, and that's Alan Woodruff. And so Alan, hopefully you're taking lots of notes because there's obviously lots of huge hopes of you, and we'd like to hear what you think about those in a moment. But before we come to you, I'm going to ask Frank to say some words about his views of things as they stand today, and then Vicky. So Frank, please. Thank you.
I'd like to start by acknowledging the traditional owners of the land on which we meet, and I pay my respects to their elders, both past and present. Questions arise as to access to the NDIS funded services for people with disabilities when these services are based on a medical model. How will the NDIS bring about a new respect for people with disabilities? How will health services system respond to individual need and choice, including visiting people in their homes at a time convenient to them? How will the health service system adjust to individuals rather than gathering people together in large herds to attend clinics. I would like to talk about people's experience with services and what I expect should be the new norm under the NDIS and the social model, with the services coming to our homes at a time of our convenience. Since 1993, I have used a ventilator overnight to assist with my breathing. This service was originally provided through the old Fairfield Hospital and then the Austin Hospital, which now manages the medical side of the Victorian Respiratory Support Service. For many years, people with severe disabilities requiring 24-hour respiratory support had to live in Fairfield Hospital and then the Austin Hospital. In late April 2007, following 10 years of advocacy lobbying by the Australian Ventilator Users Network, people using ventilators transferred from the Austin Hospital to 4 community residential units in Thornbury. Government funding was received to build a dedicated accommodation in the community and run the services. This is now the Ventilator Accommodation Support Service, which is currently managed by Urella. For over 40 years, people remember the example of Ed Roberts, a leading US disability advocate who used an iron lung and lived in his own apartment with the assistance of support workers who were funded by the US government. This has always been the dream of all of us who have a severe disability and require a ventilator to help us breathe, getting government support to help us live in the community, either staying in our own homes or living in a small apartment. The NDIS is, of course, now seen as the way in which we can achieve these dreams. Presently, VAS, Victorian Accommodation Support Service, is under severe pressure from DHS and the service provider to cut back costs, which is resulting in untrained overnight staff being employed. Cutbacks in training, in complex medical procedures, recreation services, vehicle services are a few of the problems being encountered by the residences of VAS. While DHS and the service provider may be beginning to learn how to support people in their homes or apartments to be more independent. When it comes to group homes, they are still locked into the past, attempting to continue to run community residential accommodation on the cheapest budget possible, and while paying lip service to the principles and philosophy of the NDIS and independent living. They are prepared to cut back services to meet their own financial goals rather than better living conditions for people with disabilities. Unfortunately, many senior managers of service providers are more used to be told what to do by DHS and that they do not and will not challenge government to provide more funding to residential services so that people living there can have a high degree of independence as they would if they receive funding to live in their own homes. Advocacy groups such as Australian Ventilator Users Network are needed more than ever as more and more residential units transition from block funding by the state government into a new funding formula under the NDIS. Unless drastic action is undertaken, then the NDIS funding model for residential units will not be any better than is currently provided. This will mean that service providers have to take a stronger stand in determining the new funding formulas to ensure that the new models of community residential units are about people becoming more active members of their communities and even moving out into their own apartment or returning home with full services the NDIS can offer. Our future challenge will be to ensure that the National Disability Insurance Agency bureaucracy does not continue their old funding models for community residential units, which work on being the cheapest model possible, rather than empowering all residents to be active within their communities and regularly visits friends and family. Thank you for this opportunity to speak to you today.
Before I ask for Vicky's presentation to be run, which will be on the screen, then she'll join the panel separately, I'd just like to bring your attention to the fact that we'll have some opportunity for questions. And the way that will be facilitated is if you can use the social media hashtag, which is #AHealthyAgenda. There's a number there for sending texts. Or you can just simply raise your hand if you're in the room here, and you'll be provided with some paper which will then be passed on for your question to be read out. It's very difficult to have roving mics in a very short length of time, so unfortunately we're managing that in this way just now. So if we could please ask for Vicky's tape to be run, that'd be very kind. Thank you very much.
Vicky Wilkinson, A Healthy Agenda, exploring the interface between health and disability. Vicky's support needs are high and complex. By choosing to live in the community rather than a nursing home, Vicky balances risk and compromised support with freedom and lifestyle on a daily basis. This juggling act takes a toll.
I went into the nursing home at age 45. I was there for nearly 4 years. At the end of the 3rd year, I married my fiancé, Michael. After a couple of days, I went back to the nursing home and realised nothing had changed. After being in the nursing home for a while after we got married, I made a decision and ran away one day and came to my husband's house, where I am today.
Vicky receives limited state disability funding. This funding was barely adequate while she was living in a nursing home surrounded by 24-hour support, and is grossly inadequate now that she's living in the community where she no longer has on-call access to personal care and support or healthcare products and supplies. Vicky's attempts at increasing this funding have been unsuccessful.
Unfortunately, I did have to go back to the nursing home a couple of times in that time for medical issues, but I have to tell you that reinforced I couldn't wait to get away, to come back to Michael's house, and despite what we did or didn't have, I knew that it had to be better. And we were prepared for that. I would stay in bed on my own a lot, my husband would work, and we would have very few care hours. Despite all of that, we were determined to make a go of it, and we have. When I talk about living with the compromises, what I'm specifically referring to is the compromise that you have where you have your expenses versus care hours that you can use. And the dilemma that I faced, and I do face, is how do you weigh up what you use, because the care hours is very, very important. But at the same time, the expenses are what allows you to keep going. Medical expenses that you need, or medical equipment, aids. They're the things that are so essential for your survival at home. This might seem nothing to anybody, but to get cooking done, meals done, it means I go without personal care. And that has its own compromises when you don't have the personal care. It means that I might not get a wash for that week. Another example of this issue is whether I use the disability funding for care hours again, or do I use it to pay for consumables. That includes catheters, that includes the equipment that you need with catheters, pads, the pants to go with it, and the other allied medical things that you need on a everyday basis, but you've got a budget for on a weekly basis. So this weighing up invariably means that you have to pay for the consumables out of your own pocket, because the carer hours are quite precious. If I don't have two carers to get me up out of bed, because it needs two carers to get me into the lifter and then to put me into the wheelchair safely, then I don't go out. Because you can't go I'm not able to go from the bed to the wheelchair walking. So I miss out on going to a lot of places. Sometimes your disappointment and the distress is so deep that there isn't a language to express that. And I just wonder, where does this end? To say that there's money in health and disability, there's 10,000 million kilometres between me and that at the moment. And there really is. Because when you're living this and you have a disability, it's not 9 to 5. That in order for us to live in our community, be part of our community, to be relevant in our community and not displaced. But unless this issue is urgently addressed, we could be facing the rest of our lives like this.
summerfoundation.org.au.
So we've heard some very impassioned views of what the system looks like from our panellists, and certainly some real-life experiences as well, which I think are always very powerful, especially when we hear directly from those people who are living that life just now. And really, I suppose all eyes are down to Geelong at the moment, where NDIS is starting to do its work, and the NDI has its work cut out for it down there. I was wondering if we could hear from Alan at the offices down there near the NDIS office in Geelong. Can you hear us, Alan?
Yes, I'm here.
That's very good.
And I've managed to listen into all of the conversation, so I'm looking forward to sharing some of our experience with you.
Well, it's very kind of you to be on the line, and I think obviously you, your organisation, the NDIS and the agency have got a massive role to play into the future. And I know it's very early in the evolution, and we're going through the 3 trial sites just now, but the big transformation is not that far away. So I was wondering if you could maybe give us a bit of a picture of, and it has to be a brief picture of course, of where you see things when you're looking at this particular sector, and the need to identify people with a brain injury as an important part of your business, I suppose, and also a part of the business not to ignore, and that housing element as well. So please feel free to tell us a little bit about your thoughts about that.
Okay, thank you very much for your time, and I'm so sorry I couldn't be there. This is an issue of some confusion at my end about where I was meant to be, and I do apologise for that. The National Disability Insurance Scheme is in its trial phase at present, and we operate out of in all 6 states and in the Northern Territory in one way or another in a trial capacity. Now obviously that's a start of a learning journey for us, And one of the things that we've learned very quickly is that young people with very complex disabilities who live in residential aged care or have other complex needs, this is very isolating. Facilities designed to care for them are rare, and they're generally not designed or resort to facilitate an active involvement of those young people with their family, with their community. The National Disability Insurance Agency needs to be part of that solution. The scheme itself provides an opportunity to fund reasonable and necessary support, and the development of individualised plans. The person-centred approach is critical to its evolution and its development as a scheme. We need to find a better place for young people to call home, including those currently living in residential aged care. And a part of that is, first of all, to find them and to connect with them and to understand and to work with them around the opportunity. The National Disability Insurance Agency, though, is not the panacea for all of the problems. The National Disability Insurance Agency provides better funding, more individually based funding for people with a disability. What it needs to do and what we need to do and what the health system and rehabilitation systems need to do is work together on the continuum of support for people. We've heard today a lot about the interfaces with healthcare, the interfaces with rehabilitation, and whose responsibility all of this is. And the reality is it's a shared responsibility for all of us. The National Disability Insurance Agency, at the end of the day, is a funding agency who has now resourced and will be resourced going forward to fund disability supports. Those disability supports, and we've heard something today about equipment and vehicle modifications, home modifications. These are the kinds of supports that will help people, firstly, not be admitted to unsuitable accommodation and to find their own place in the community, but secondly, to make sure that we are getting that right and getting the maximum opportunity for people to enjoy a life worth living for them. We need to do that in cooperation with the health and rehabilitation system. The legislation that drives the National Disability Insurance Scheme is very clear that it is not there to pick up gap holes or cracks in the system and fill them with National Disability Insurance Scheme money. The health system has a role to play, and as does the system of rehabilitation. But what we need to do is work together in things like discharge planning forums, nursing home unit managers and forums that we can work with, aged care association networks where far too many young people are still housed, to maximise the opportunity to connect with younger people and to identify supports and services that will help them to live more independently and more connectedly with their family and their community. The reality is that to give young people or people living with a disability the best opportunity to achieve their personal goals and outcomes requires a partnership approach with healthcare providers, with the rehabilitation system, and it requires us to adopt a position where we have a shared responsibility in a person-centred way for ensuring that the primary healthcare, rehabilitation and disability supports are integrated and work seamlessly to provide people with opportunities so that people with a disability, when they're discharged, are discharged with the right equipment and the right supports and the right understandings of their housing needs that will help them to maintain optimal living independently. Now, I don't say that that is not without challenges. There are chronic shortages in infrastructure. There are chronic shortages in our ability to identify suitable accommodation options for people. These are challenges that have existed in the health and the disability systems for many years. And whilst the National Disability Insurance Scheme will play an important role in driving change in these areas, the National Disability Insurance Scheme is not funded to do these things itself. The National Disability Insurance Scheme will provide the disability supports but that doesn't alter the greater community's responsibility to help young people or all people with a disability to live the life that they want and to get them the supports that they need. That's not the sole responsibility of our agency, but our agency will play a critical role. It's an opportunity. The nation has presented a broad agenda for social reform that is the National Disability Insurance Scheme. It will provide the opportunity of having more funding for disability supports moving forward. It will be a very challenging rollout. As it stands at the moment, the scheme at the end of its trial phase will have around 35,000 participants in the scheme. Within 3 years, that is expected to rise to 400,000 plus participants in the scheme. That's not going to result in everybody getting everything that they want or they need as quickly as any of us would like. This will take time. It will take an evolution. It is not only the agency that needs to evolve and to understand these things, it's the whole community, the health system, the rehabilitation system, the accommodation providers, all of the elements of the system that support people with a disability need to change, evolve and develop to understand and to integrate the supports that people need to live in the community with dignity, respect and connected to their family and those close to them who love them. I'm happy to leave it there and I'm happy to answer any questions that people may have. Thank you very much for listening to me.
Thank you, Alan. I think, Alan, the agency has not been going that long and your role is relatively new too. So you've, I think, picked up many of the pain points that people feel across the sector, and I applaud you for doing that in a very short length of time that you've been exposed to it. That's really important that you do have that sort of guidance in your thinking. Thank you. We have a question that I'm going to ask to be read out over there from Tom, please.
Yes, thank you. We've got a couple of questions actually online from Newcastle. One's following on some information that Jackie and Jacinta have mentioned around the transition issue. I guess this is directed to you, Alan. There's a question about efficiency, about how do we actually make sure that the NDIS actually does do things in a quick enough way to allow people to get what they need as they're in a discharge phase. So is the NDIA doing anything active in terms of setting up systems with the health system to allow that process to be done quickly?
I think that one of the things we are doing is developing a system of supports coordination, but there is much more we can do in this space. But the first and foremost thing is that we need to get people working with through discharge as soon as we possibly can, who can identify the supports that will be needed for them to return to community, to family and to home. So part of that is to integrate as soon as possible in the earliest phases of planning a system of supports coordination or access to local area coordination that will enable us to both to connect with those people, to understand the needs that they have, to work with those who love them, to identify the supports that will enable them to move through that discharge planning process. But I acknowledge that there is much more that the agency needs to do to raise awareness with the health system of what we can do and to raise awareness with the health system about ensuring that we are aware as soon as can be of people who are likely to need National Disability Insurance Scheme supports so we can fast track their access, identify supports coordination and local area coordination working with the hospital in the discharge process to ensure that as close as we can to discharge that the supports are in place, enable them to return to community.
Thank you. I dare say you might have a view on the coordination in the health system. Maybe you could embroider on that, Jackie. Having been a commissioner on the National Health and Hospital Reform Commission some years ago, that word system is a bit of a loose term, I think, in the health system.
It is. What we don't want to see happen, I guess, is where if we're having to deal with the different areas, that different systems are in place. So we don't want a system where if you're having to deal with someone in the south, then there's this much waiting time or whatever it might be. So I think we need to be really important from the start that the systems that are put in place are equal across all systems. So there's consistency. So you don't have to think, I'm dealing with this region, I need to do X, Y, and Z. So I think it is really important that there's a coordinated approach to what the role of and responsibilities are of the health system. Being someone who's worked in the health system for most of my career, I can assure you that discharge planning does start on day one, and that it is often the systems that we're trying to get to discharge someone that is the delays. So we do work with the discharge planning from the very start, and we often do identify what the needs are very early. And I guess we have a model where we're working with TAC at the moment within our rehabilitation, where we are setting early engagement with TAC so that when the person is ready for discharge, all the systems are ready to go. And a system such as that, where the NDIS areas are coming in and working directly with the healthcare workers in the rehabilitation or the acute settings or whatever the environment be, would be a fantastic model, I think, to start with. So early communication, but face-to-face communication, so everyone knows what to expect, whose responsibility it is, and so it's very clear.
Thanks, Jackie. I was wondering if Vicky or Frank had anything to add to that, the whole coordination piece. Has that been something you would have say was a difficult thing for where you've come from? And how would you have any thoughts?
I mean, at the moment, health services generally take over people's lives, and I think the treatment as an individual within health services is, as I've talked about before, based on the old medical model. And so the new thinking for health services is to see them not as themselves as running people's lives, but as a temporary phase in which people need health services on a regular basis or on an irregular basis, but as part of of life, and that we need to get back to the fact that all people with disabilities need to have control of their lives, so that when they're participating in health services, whether it's acute medical or it's rehabilitation, that's got to be seen as adding to their lives rather than just curing them medically. And so it's for me, it's all about health services, how health services can make my life better rather than warehousing me for a while I get better or be rehabilitated, and then someone else deals with me. So the philosophy under the NDIS is based on the convention, which is all about the social model. And in the future, health services have got to pick up this philosophy and treat people as respectful individuals who need health services for a while, but then the goal is for them to get on with their lives, not to be forever controlled by health services.
Thank you very much. Please, Tom.
Had from Newcastle is around from Janine from Wesley Mission, who's saying that she's come across this idea that you're double dipping if you're in a nursing home and you're also getting access to the NDIS planning system. And she's actually asking how much is actually really understood by the health system about the NDIS, and what plans would be in place from the NDIS to actually help educate the health and the residential aged care system about what the NDIS can provide?
Would you like to answer that, Alan? Is that something you can comment on?
Yeah, I can try. Well, I think that first of all, anybody who's living in an aged care facility is not double dipping by accessing the National Disability Insurance Scheme. The National Disability Insurance Scheme is working, as you know, Tom, with the Summer Foundation to try to identify people in those situations and to reassure them and support them in whatever way we can to explore alternatives in their lives. We value the partnership in doing so. In terms of health systems and how the lack of awareness of the National Disability Insurance Scheme, clearly and critically, we have to remember that for the early part of the journey of the National Disability Insurance Scheme, we're working with a number of confined trials, many of which don't involve new entrants to the scheme and which have had limited interfaces in terms of that discharge stage of with disability. Obviously, as we move forward to full scheme, and now with the bilateral agreements in both New South Wales and Victoria signing up for organised rollout of the scheme, we need to ramp up our efforts in working with health professionals both in the hospital sector and in the broader community sector to understand the role of the NDIS and how we can work more effectively together to support people with a disability. I think I'd like to come back, if I may, just briefly to something that Frank just said about social versus medical models. I think the emphasis of the NDIS is on funding people's needs that are aligned to their own personal and individual goals. One of the things, though, that needs to work through that process is this integration and working with the health system to manage risks. So, in a sense, we give people the right to be wrong, but we also provide people with the certainty that those where there are risks of, for example, a readmission or those sorts of things, that we're working very closely with the health system to provide those supports that will enable the continuation of independence for people with a disability who have extracted themselves from a difficult accommodation situation and get the support that they need, both from the NDIS and from other sectors, to make sure that there is no reoccurrence or readmission.
Thank you for that. I was asking, I don't know if Vicky's able to or willing to comment on that, and if you feel at all reassured by the way forward that's being projected by the NDIS through Alan there.
I'm sorry, I didn't catch that.
No, sorry, I was just asking Vicky to give us a comment on that from where she's obviously moved out of that sector, and seeing if she would feel that what you're saying is a positive move or you'd support what's been said.
Really, in my position where I am today, and when I was in the nursing home, and when the NDIS was up to then, and where you're talking about now, to me there's still a huge gap. So I remain cautious, really, to say much.
But hopeful? Yeah, very good. Okay, we do have one last question, and then I'll probably need to wrap this up. So thank you very much for that, Tom.
Yes, thank you. This one came in through SCMS. It's regarding the concept of community rehabilitation, and the example of the ABI Slow to Recover has been raised as a really good approach to that. Alan, just wondering if you could respond in terms of what does community rehabilitation mean in terms of how the NDIS can provide for that?
Community rehabilitation is not. It's another area where we need to integrate effectively with other mainstream services and facilities, because people with a disability, in order to maintain their independence, require some access to ongoing rehabilitation support. or therapeutic supports. Those supports are not necessarily supports which the NDIS will fund in total. The NDIS will provide some support in those areas, but they're not. These are things that, as I indicated in my opening, the NDIS is not the panacea for all of these issues. But what the NDIS needs to do is to work effectively to ensure that those supports are integrated and in place, and any therapeutic supports that are required to maintain function and independence are in place to ensure that we're not only providing the disability supports that are required, but there's an integrated support that enables the person to continue to maintain as much or their optimal independence that they can, and to live in arrangements which suit them and maintain their connectedness with their families and their community. The NDIS, I don't mean to sound defensive, but NDIS is not the panacea in terms of funding everything, but the NDIS has an important role to play in making sure that we are working effectively with community rehabilitation to ensure people maintain independence. One of the other areas that we obviously need to do a lot more in is that the supports for people with complex behavioural or other needs in a community setting is a sector and a service that needs to be more broadly developed across Australia. And I think that the NDIS play an important role. What the NDIS is a game changer not only from a point of view of what it will do or what it is able to provide funding for people with a disability to do, but it's also a game changer because it develops an opportunity for services to develop which are tailored to meet people's needs. People with a disability will begin to demand the services that they require and they need to maintain functioning in the community. And it's working with the health and the disability sectors, and they themselves evolving and changing to create services that people with a disability want or need. The NDIS can provide the funding, but at the end of the day, all of us need to change the way we think and approach people with a disability so that we're beginning to provide the services and supports that they want, that they need, and that will enable them to live the best lives they possibly can.
Thank you very much. Jacinta, would you like to respond to those thoughts?
Alan, I excuse me, I endorse lots of the things that you've just said, that in a sense we have an opportunity to develop services that actually meet people's needs, and community participation is essential, and providing support for community participation is essential, and there needs to be those appropriate support services available. And I think sometimes what we get is a mixed message when we talk about community rehabilitation and support to participate in the community. And really the goal of community rehabilitation is inclusion, is connection, which are all part, if you like, of the philosophy of the NDIS. So it is important that we give services the opportunity and almost the pressure via us as individuals who can access those services to develop the services that enable us to be fully included in society and connect within our own communities. So I think it's almost a bit of a red herring to talk about community rehabilitation and support services in the community, because in many ways I see them as being the same types of services. Does that make sense?
Thank you very much. Well, look, I think we'll have to pull this to a close, so I'll just make a comment. You disagree with me? No, that's good. Just making sure I've got my, it keeps, you know. Anyway, I just want to, first of all, finish off with the conversation we've had with Alan in particular, who's been giving some good guidance about the way the future is looking. And my observations are that we've heard from the various sectors that there's a lot of work, I suppose, to be done to understand how you are doing your work and to involve the sector. And that sector doesn't just include the providers in the health and the providers in the welfare sector, but also the community members themselves. And the question that came to my mind is, how would we do that? And we do that through the advocacy groups that we have. And today, the group we've seen is the Summer Foundation, and the advocacy they've provided thus far is the sort of advocacy we should be looking to provide further into the future. I'd just like to ask you if you would thank me one by one to Alan on the line coming in from Geelong, please. And if you could thank both Vicky and Frank for their very kind time and participation and their very thoughtful comments, please. And for Jacinta and Jackie with their wealth of knowledge from the sector. And I'd like to hand back to Di, who will finish off the proceedings for us.
Thank you. Thanks for the panel. A really thought-provoking and helpful presentation. And I guess we're sort of in, we have broad agreement in what we want, but the real challenge is how we actually get there and how to get that consistency across jurisdictions and across regions, and that seamless coordinated approach is one of our next challenges. So thank you again to the panel for terrific presentations and discussions. I'd like to thank everyone who asked a question here or online, and I'm sorry that we weren't able to answer everyone's questions, but we'll try to answer them more on Twitter and on Facebook. And through social media, we'd really like to keep this conversation going. I'd also like you to invite you to take a copy of our 2015 annual report home with you. They're available at the registration desk. And thank you to everyone who's watching online, people, especially our audience in Newcastle and Geelong. Thanks to NAB for this fantastic facility. We really like this space and we really appreciate it. Thank you to everybody who's joined us here today, and we really appreciate your support and your participation. We still have some refreshments over here that need to be eaten, so if you're able to stay, it would be great if you could join us for a sandwich and something to drink. Thank you.